All right, so that is the official kickoff, and I just want to thank everybody again. Thank everybody for logging in and joining us for the second night of the Trauma Night series. It's been fun, sort of planning this and getting it going, and thank you guys for jumping on this experiment with us. We got a great panel tonight to share with us some pearls and tips about hip fracture care across the board. I know it's a big topic, but we'll touch on some select important salient points and hopefully foster some discussion amongst everybody. So just want to give a bit of a brief intro. We went over some of this last week, but as we all sort of shift from our real podiums to the virtual platforms due to Corona, we have adapted to this across our various subspecialties at Mac Ortho, and we started with a virtual speaker series for pediatric orthopedics, as well as sports and foot and ankle, and we stuck to the traditional format of one night, one lecture, but with trauma, we figured there was the potential to do something a little bit different, and we've included members from across Canada, from the Canadian Orthopaedic Trauma Society, and then from there we were able to actually reach out globally, because there's so many great networks to connect with, and we're bringing that together for our residents or fellows, as well as our colleagues locally, as well as across the country and across borders who want to join the discussion. So before we jump in, I just want to remind everybody that the event is being recorded tonight, and we ask that while people are presenting, just keep your microphones on mute and try to turn off your video, just so we can keep the attention on the speakers. And during the discussion, we'll ask you all to turn on your videos and unmute and join in and ask some questions, either just speaking up or typing something into the chat box or raising your hand with the Zoom app. And I just want to go over and I think we just have this covered here. So I just want to go over the fact that we have a series of lectures over the coming basically few months right to the end of June on June 24th is when we finish. We had our first session last week on polytrauma, and we'll have another session next week on patient recovery. And then we'll have our first case session. So listening to some feedback on the first rounds, we definitely appreciate that everybody wants to see some cases. So we'll try to we'll sprinkle the cases throughout the talks, but we'll have a focused 1 hour session just on the cases based on the content from the previous few weeks. So look out for some announcements for those. And that will basically be happening every third week as we continue to finalize our excellent schedule, and our presenters will be sure to keep everybody in the loop with frequent emails. So check your inbox. Once again, I'm Herman Johal from Mac Ortho, Director of Trauma here locally. And we've taken this on as an initiative, but really, I'll be the moderator for some of the sessions, and we'll be sharing the honor with many others from Mac Ortho, as well as across COTS. My disclosure personally for this topic is we do have some support from some companies locally here, and I work at the Hamilton General, which is a level 1 trauma center. We primarily focus just on high energy trauma. And we actually have our hip fractures, low energy hip fractures, go to one of the other sites in our center primarily. But that doesn't mean I don't see hip fractures. So I tend to end up with a high energy younger patients, but there's a variety of things to discuss with hip fractures, and there's a variety of reasons why they're important. Don't have to convince the audience tonight, but we all know why hip fractures are critical. They're costly, and they have a huge impact on patient morbidity and mortality. This is why there's so much interest in here on this topic. There's lots to discuss, and I just want to direct you guys to some resources. Dan, one of our residents, will be pasting some links in the chat that you guys can use to access some of these. And here's a nice review article by Dr. Mo Bendari and Mark Swiatowski on across the board treatment of acute hip fractures. We have another resource out in the BMJ best practices that talks about, again, the variety all the way from young to elderly hip fractures. And then, we've been lucky enough to spearhead some of the largest studies on hip fractures at Mac Ortho, as well as with COTS in a global network. One is looking at fixation options for femoral neck fractures, and both old patients as well as younger patients. In this particular study was spearheaded by Dr. Slobogean, who'll be on our panel tonight and discussing more on that. With respect to elderly hip fractures, another big question is what to do with respect to replacing. Do we use a hemiarthroplasty or bipolar? And the health trial helped us answer that question. Again, a large study, nearly 1,500 patients in a randomized controlled trial. Lots of new data out there, and actually an excellent summary I'd like to direct you guys to is in the JOT supplement from last November. It gives a good summary of both faith and health, and gives an excellent presentation of all of the secondary papers that are out there. So those links will be kind of popping up in the chat throughout tonight. And as we continue on, I just want you all to keep three different kind of variety of hip fractures in mind. Sort of on the right, or sorry, on the left there, we have an elderly hip fracture, ground level fall, low energy, and looks, and this is a CT cut that shows it's a valgus impacted hip fracture there. The one in the middle, that's a patient presenting with hip pain. And if you look closely, you can see a fracture line sort of just in the subtrochanteric region with some beaking and cortical thickening. This patient was on bisphosphonates, and we'll potentially be talking about some issues around that and pathologic hip fractures in general. And then the last is a young high energy hip fractures patient was an MVC. They're in their mid-20s. They had this in an association with some hip fractures as well. And we'll kind of think about all of these three types of different scenarios that have some similarities as well as some very important differences. And we'll be bringing the end of our case at the end of our night to conclusion with hopefully reviewing some concepts related to those. And I just want to go over the schedule for tonight. So we're lucky enough to have 4 great speakers on our panel. We'll be starting with Dr. Ross Leighton, who's the current COTS president. He is out at Dalhousie, and we're really honored to have him share his wisdom and experience with us tonight. He's going to be talking a little bit about Canadian ortho and ortho trauma in Canada, and specifically we'll be talking about elderly hip fractures. Then we're lucky enough to have Dr. Flavia Borges, who's one of our non-orthopedic colleagues joining us tonight. And she's, we're lucky enough to have her here at McMaster in the Department of Internal Medicine. And she's taken a huge interest in hip fractures and really the perioperative management of these patients. She was one of the lead investigators in Hip Attack and RCT looking at timing for these hip fractures. And Hip Attack 2, which will be coming, is in the process of getting started, and hopefully she'll be sharing some details of those 2 studies tonight. We're also lucky enough to have Dr. Theresa Pazionis, who's one of an alumni from McMaster, graduated from here for her residency, and she's gone on to work at Temple University. She was previously heavily involved in ATLS while she was here, and she's part of the trauma team at Temple. She also specializes in ortho-oncology and spine, and she'll be sharing information on pathologic hip fractures with us tonight. And we, last but not least, have Dr. Gerard Slobogean, who it's an honor to have with us today. He is an expat, did his residency at UBC, and managed to get a master's of public health at Harvard while he was doing that. Did his fellowship at Shock Trauma, and now is attending at Shock Trauma, as well as the director of research there, which is no surprise to those of us who know how prolific he is with respect to research. He's also heavily involved in lots of RCTs around hip fractures. I mentioned FAITH 2, and also is taking a lead role in Hip Attack 2 as well. And he'll be sharing some information with us tonight on young adult hip fractures. So with that being said, I'm going to turn it over to our first speaker tonight, Dr. Ross Leighton, and I'll ask him to start sharing his screen with us today. I'll stop mine there, and I think he can share.
I'm gonna start my slide somewhere. Great. So you guys see that?
Yeah, and I think if you just hit the slideshow on the bottom left there, it'll go full screen. Bottom right there, sorry. There you go.
There we go. Okay, so just been asked to do a couple of things. So one, I just would go over some of the sort of where Canada came into play with emergency care, and where COTS came into play with that, and kind of go through how COTS came to be, and how it became influential in trauma care within Canada and within the world, really. So this is Birmingham. The first time they had a trauma hospital ever was in 1935, when they decided that trauma needed a special center. So everyone took their cue from the UK. This is Leo Tzu, who says the leader's best when people barely know he exists. When the work they has done and the aim is fulfilled, they'll say we did it ourselves, and that's kind of how it's done here in Canada. So the first daytime trauma ORS was actually in Halifax, and I came back to Halifax. Sunnybrook had a room at that time. It was a wait list room for anybody, sort of first come, first serve, but we had the first trauma room for orthopedics. And I think really that led the way to make orthopedic trauma a viable subspecialty for this generation. So things you can do most of the trauma during the day makes a big difference if you can do it during the day as opposed to 2 in the morning. So the Canadian Orthopaedic Trauma Society is really a model for success in orthopedic clinical research. We had a small group of surgeons back in 2001, very modest beginnings, and we've grown up to a surgeon group of 70 and a lot of clinical researchers as well. So the past decade, COTS research has received some of the highest praise and presentations acceptance associated with orthopedic outcomes. Finally, remember a mentor of mine, Dave Petrie, and Bob McCormick and I sat down over a beer one time and discussed a few problems. We decided we'd look at proximal humerus, and we did a CT classification, think we'd be really smart, and it just made matters worse as far as we were concerned. But I think that's what it showed ultimately, but we didn't publish it. So it started very humble with a study that didn't work. Anyway, we sort of went on to the next study, which was the calcaneal study with Rick Buckley, and Bob Meek was there, Dave Petrie, Bob McCormick, Rick Buckley, and myself, and sort of laid the groundwork for the Oscalsa study. We met in 1992 and got some funding from the Workers' Compensation Board, if you can believe it. So that's pretty cool. And then first step was really to get a development where this would sit within Canada. So we decided, should we go in our own group, or should we actually make it within the Canadian Orthopaedic Association? And legally and from a funding perspective, it appeared much more direct and advantageous for COTS to stay within the COA, use the Canadian Orthopaedic Foundation as a research fund depot. So that's what we did.
Now, Ross, I'm just going to stop you there. Can anybody see see the screen? Because I'm just seeing faces. I just want to confirm.
Oh, really?
I just want to see if anybody else is having the same. Can everybody else?
Hey, Herm, I can see the slides.
I can see the slides.
Okay, I think it's just my.
Yeah, it's all good.
It's on my end. Okay, sorry to interrupt. Keep going, Ross.
No problem, no problem. I'd rather you tell me than me thinking everything's going great.
Oh, you're going great. I think it's my end. So
nothing's worse than thinking you're doing great and everyone says we can't see a thing. So.
Oh, you definitely are. So I'll fix my.
Okay, very good. Anyway, the idea is to allow our centers who are able to get involved with every study and get some input into every study. Not that you can participate in every study because everyone's busy, but the idea is to get everyone involved with all of the protocol developments. So much so that someone said our COTS was really compromising orthopedic trauma surgeons, because there's no questions that we all had to compromise individual protocols in order to get the studies done. So our ability to ultimately agree on a protocol for all our centers and stick to that protocol for a significant length of time really differentiated us from any other group at that particular time. Even now, it's very difficult for our United States colleagues to do what we do, just because they have a difficulty staying on course with a certain protocol for greater than a year or two. So it's very difficult for them to do that for many other reasons. But we're lucky because our health study and our health organization in Canada will allow us to do that. So the stick to protocol really is particularly hard when technological advances happen. You get new shiny locking plates and IMHSs, et cetera, and it's hard to stick to the old school things to see if they work or not. So we recognize the importance of having research coordinators participate in meetings, and we did that very well. And plus the idea of the research coordinators take on more and more tasks, and then keeping the surgeons focused and on target with getting our studies done, are of course most important with getting through these randomized trials. Coordinators' ability to solve day-to-day issues quickly and amongst themselves truly makes a seamless environment in which to run these multi-center studies. And anyone that wants to get involved with the COTS group are more than welcome to do that in Canada. Just let me know. We can certainly tie you into our study group. And if you have an interest in a certain study, we'd get you involved with it for sure. Our goals have been modest, but results have been outstanding, and randomized prospective trials have been practice-changing and impact on the global orthopedic family. So what do? We develop a protocol. We present the protocol to the group. They all have in common as a champion who's open to feedback from the group. And all of us have stood in the front of the room thinking we had a great idea, just to be kicked back and told to come back next year with a better idea. So first is to ask the colleagues if they feel it's worthwhile answering. Is it a controversy or debate in treatment? Do we need a prospective randomized trial to answer the question, would a different study be better? Questions incite interest, and the principal investigator presents the proposal to the group for further input prior to putting the finishing touches on the protocol. Common items for debate include study design, primary outcome measures, subject selection, and follow-up schedule plus standardization, and then of course a budget to do that and what we need to, who we have to present to get that budget. So right now there's over 70 surgeons and 24 research coordinators that comply with the COTS group that really make for interesting meetings and very dynamic research groups. Lots of examples, of course, of what's been presented to you guys in the past with the clavicle fractures, IM nails with minimal reaming started in Canada, all sorts of things that oscalsis fracture classification and treatment, of course, was in Canada. So all sorts of these things have come from the COTS group and been worldwide recognized as stellar organizations and stellar research. These have been accomplished with all authors and coordinators working hard to really make sure our data is clean and well presented. And we're really noted for that we have very clean, well presented data. We've become a go-to group for anyone wishing to get really good, credible numbers and know the study will be completed, provided level 1 evidence with a well-powered study. So it's happened with many of our studies have been industry coming to us to look for someone to do these studies. Again, the Edwin Bovell Award is an outstanding award through the OTA annual meeting, and COTS has won 13 of 18 Edward Bovell Awards from 2000 to 2018. 8 of 13 were COTS alone, and 5 out of 13 with COTS with a larger combined study. So really, we have excellent succession planning. Not every center can commit to every study, but the idea is to get as many people involved as possible and make sure everyone's had an input into the studies so they know it's well done, will be well presented. We've also shared our data with other groups. This is the COFAS group, who started in 2002 and then had a think tank in 2009. And they presented numerous papers that have all become a well-known group, but based on our philosophy, our bylaws, and our input as well. We have endowment funding. We present our own seed funding for $10,000 for investigators in the group under the age of 40, and preference given to well-designed, prospective, randomized, multi-center trials. So the Canadian members and COTS have always felt that the OTA is our trauma organization, and this has really been heralded by Emil Shemus, had just been elected as the second president-elect of the OTA 2021, so remains a very special organization for Canadian orthopedic trauma surgeons. So stay tuned for good things from Emil. So I'd like to personally thank and publicly thank our entire COTS group. The dedication of the whole team to the common goal at hand has really driven the process to the success it achieved to date. So anyone that has any questions, of course, you can go to our website and contact any of the surgeons involved. And thanks for allowing me to present on the COTS group. Do you want me to just carry on with the other one, or do you want to go to a different presenter there, Herman?
No, it'd be great for you to keep going and share with us some words on elderly hip fractures. So thanks, thanks for the primer on COTS, and now to jump into our topic for the evening.
Okay. You guys can see that okay?
Yeah, I'm coming through now. It's coming through on my end, yep.
Oh, I'm sorry, I had to back up there.
No problem.
Okay.
Yeah, I think if you just scroll to the top there and just click on the top left slide there, the number 1, and then it'll take you.
Okay, thanks, Aaron. Okay, so on to the topic. Sorry about that, the delay. Treatment of the displaced subcapital hip fracture in the elderly. This gets closer to home to me all the time, so I want you guys to listen very carefully. Projections indicate by 2050, the number of hip fractures occurring worldwide each year will top 6 million. So that's kind of something to think about going forward. When treating displaced femoral neck fractures in the elderly patient, replacing the femoral head is the preferred treatment in the majority of cases. Roden, of course, showed that 64% treated with open fractures required reoperations versus 6% in the bipolar group. Parker and Partnan also showed a significantly higher reoperation in ORIF groups compared to hemiarthroplasty groups in the displaced fractures. Mobanderi and the McMaster group, of course, has performed a meta-analysis of the outcome of displaced femoral neck fractures and showed the reoperation as high as 35% in our open reduction internal fixation group. So the indications for femoral head replacement appear to be at this present time: displaced fractures in a patient over the age of 60, antecedent osteoarthritis, inflammatory disease involving the hip joint, poor operative risk with some with reduced lifespan, and poor bone quality that stable internal fixation would not be possible. So what are the choices? Really, it's bipolar or modular unipolar versus the total hip replacement in today's world. So a cemented stem has been considered the standard of treatment of this elderly population with osteopenic bone. The cement is utilized to create instant stability of the femoral stem to permit early weight bearing, and this has shown up in many studies to reduce the stay in hospital because they're able to walk on it much sooner. It has been very predictable long-term results, but historically been associated with increased risk of dislocation in the total hip arthroplasty group. Some of that's changed, as I'll show you. Proponents of total hip argue that very successfully reduces the overall cost due to its improved long-term survival, but that's probably needs about 8 to 10 years to really show an improved cost analysis. Absolute indication for total hip continue to be patients with antecedent symptomatic osteoarthritis, whereas a revision for a failed ORIF or failed hemiarthroplasty. Total hip versus hemiarthroplasty has gone back a ways to Dorr et al., which showed no differences in mortality and pain, but higher dislocation rates. There's a number of randomized prospective studies which compare open reduction internal fixation, total hip replacement, and all three confirm better results with total hip replacement. Parvizi showed some interesting information showing that perioperative mortality was more than doubled when cement fixation was used. We looked at this at Dalhousie, and our own center reported the COA showing 120 patients, 80 cemented, 40 uncemented. We did have higher perioperative deaths, just as reported by Parvizi, but the death rate at 6 months was no different. So you had earlier deaths in a subgroup of patients, which none of us like, of course. No one wants to take the paddles to our patients in the middle of the OR. However, when you looked at the 6 month rate, there was really no difference. So the only thing I'd say for this is strongly consider performing an uncemented femur when a patient presents with a high risk factor for cardiovascular disease. And this cardiovascular disease has really been validated cardiovascular risk factors by Carson et al., who show in this subgroup an uncemented femoral component may be the safest and best option. So why has cemented hemiarthroplasty remained the favored technique for this fracture? It's really because of an extremely low dislocation rate, good 8 to 10 year follow-ups as reported by Mayo and Hajdukowicz. And the Hajdukowicz study really shows that in those patients that survived 10 years, 94% had superior outcomes, 99% had survival for acetabular cartilage wear. So when you look at that, some people in the United States say, what's the difference between modular unipolar versus a bipolar? And there's really no difference, same outcomes. So a modular head with a well-fitted or cemented femoral component appears to be the ideal implant for most patients with displaced subcapital neck fractures. Will things in the future change that? Well, we just had health study done by the McMaster group and others, and it really shows that cement seems to perform better than cementless in this elderly age group. Hip instability or dislocation occurred in 34 patients assigned to total hip versus 17 patients assigned to hemiarthroplasty. Function, however, was modestly favored total hip arthroplasty over hemiarthroplasty at 2 years. That's important because longer, I think it would probably show a little bit larger difference. It's only a 2-year study, so long-term improvement with the total hip would not be expected to show a significant difference before 8 to 10 years. However, there was less femoral shaft fractures and calcar fractures in the cemented group. This is almost the same with the advent of offset. The dislocation rate seems to be almost the same with the advent of offset liners, larger heads, MDN components. So again, the ability to have a stable hip and not lengthen it is much better today than it was in years gone by. One thing that's not been looked at very carefully is really what are the types of total hips that are put in these fractured hips. There's tri-taper hips, dual taper hips, and distal fitting stems, and proximal distal fitting stems. And the top two, I'd say, tri-taper and dual taper, have the highest fracture rates. So be careful with those in elderly patients. So Ng et al. Showed that the AML style of cementless stems with press fit proximally and distally seems to be a good fit for elderly patients with equal femoral fracture rates to those of cemented stems. What's the approach? Keene and Parker shows really no difference in the approaches for a dislocation. So do them well, do them what you know best, and it should be about the same. The cost analysis, again, have shown cost effectiveness in surgical treatments. Using this methodology, the cemented total hip was the most cost-effective treatment, while internal fixation was the most expensive. But again, a number of years has to go by for that to be effective. So in summary, our center, the elderly patient with a Garden 3 or 4 subcapital fractures is routinely treated with a cemented bipolar arthroplasty. Cementless stems are utilized in 2 subgroups, patient with good bone quality and a canal diameter of less than 16.5 millimeters, or a patient with high-risk cardiovascular risk factors for cardiovascular disease. Following these guidelines, total hip replacements can be supported in femoral neck fractures with associated hip disease, significant symptomatic contralateral hip disease, a highly active patient, or extremely cooperative patient resembling an elective patient, really. So we've been reticent to extend these criteria for total hips in patients with femoral neck fractures much beyond these indications, and that's been supported by the health data. So in displaced stable fracture, perform an ORF. In displaced fractures, replace the head of the femur with a modular hemiarthroplasty. That's been the most reliable, predictable outcome. And I think total hip replacement is being done more often in the active elderly patient. However, there's a dearth of long-term level 1 evidence to support this to date. So be careful, but again, in those patients that have a lifespan of greater than 8 to 10 years, I would look very carefully at doing a total hip. I'd like to thank you very much for your attention and hand it back over to Herman.
Great, thanks Ross for that great primer on how to treat these patients surgically for the elderly patients. And I think it'll be great to turn it over to Flavia Borges now to share the non-surgical side of things for important factors when we treat elderly hip fractures. And she'll be sharing some information with us about timing.
Okay, can you guys see my screen?
Yeah, it looks like you just gotta go to the slide mode. Perfect. Yep.
Yeah. Okay, so thanks everyone for the opportunity to be here and present for you the HIPATEC trials in regards to timing for surgery in hip fracture patients. I have nothing to declare, but I'm not an ortho, I'm GIM physician working in the preoperative care team at McMaster. So in regards to the HIPATEC 1 trial, the background is that in observational studies, accelerated surgery is associated with lower mortality and major complications in hip fracture patients. However, until HIPATEC, we didn't have any RCTs on this topic. The main objective was to determine whether accelerated surgery for hip fracture was superior to standard of care in reducing death or major complications. We perform a randomized controlled trial, including patients with 45 years old or greater, diagnosed with low energy mechanism hip fracture that requires surgery. We did exclude patients on therapeutic anticoagulant without any available reversal agent, periprosthetic open or bilateral fractures, and also patients requiring emergency surgery for another reason. The intervention was accelerated surgery with the goal of surgery as soon as possible, but ideally within 6 hours from hip fracture diagnosis. And we did compare with standard of care. We had 2 co-primary outcomes at 90-day follow-up, all-cause mortality, and a composite of major complications, including mortality or non-fatal myocardial infarction, venous thromboembolism, pneumonia, sepsis, stroke, life-threatening, or major bleeding. We recruited 2,970 patients in 69 centers, 17 countries, and our follow-up was greater than 99% at 90 days. As you can see here, most common type of hip fracture was intertrochanteric in half of the patients, followed by femoral neck fracture. And 2/3 of patients had open reduction internal fixation, a third had arthroplasty. In regards to timing for surgery, we could achieve our goals. Accelerated median time to perform surgery was 6 hours in the accelerated care group versus 24 hours in the standard care group. There was no difference in regards to mortality or major complications when we compare accelerated surgery versus the standard of care. However, we did find some difference in terms of secondary outcomes. Patients with infection without sepsis had 20% relative risk reduction comparing accelerated versus the standard of care. There was also decrease in stroke, however, very few events, so we offer caution in the interpretation of this data. Importantly, delirium happened in 132 patients in the accelerated care, 175 in the standard of care, has a ratio of 0.72, p-value highly statistically significant. In regards to types of infection, the infection that was driving the effect was urinary tract infection. There was no difference in regards to pneumonia, surgical incision, joint, or surgical abscess. When we look into tertiary orthopedic outcomes, there was no difference between the two groups in regards to hip reoperation, prosthetic hip dislocation, implant failure, periprosthetic fracture, or surgical site infection. When we look into timelines, we can see here in this table that accelerated care patients had 21 hours earlier mobilization and standing, and also 26 hours earlier full weight bearing compared to standard of care. Also, patients in the accelerated care were discharged a mean of 1 day earlier compared to standard of care. Patients in the accelerated care had better moderate to severe pain scores, days 4 to 7 after randomization. And we did perform the subgroup analysis looking into 90-day mortality based on patients that arrive with a troponin elevation compared to patients with no troponin elevation. This was based in actually the index case that motivated the trial. That was a hip fracture patient with troponin elevation that cardiology got involved to clear the patient for surgery. And as we know, patients with troponin elevation, they have a higher risk of mortality. Here you can see in the standard care group, mortality was 24% compared to 8% in patients with no troponin elevation. And interestingly, patients that underwent accelerated care with troponin elevation had 10% mortality compared to the 24% mortality in the standard care group, has a ratio 0.38, p-value statistically significant. So the takeaway message from HIPATEC 1 trial are that among patients with hip fracture, accelerated surgery did not lower the risk of mortality or major complications. However, there was no evidence of harm even in the subgroups with acute medical conditions. Accelerated surgery demonstrated lower risk of delirium, urinary tract infection, and pain, also was associated with faster mobilization, standing, full weight bearing, and shorter length of hospital stay. And accelerated surgery demonstrated mortality advantage in patients with elevated troponin before randomization. The HIPATEC 1 trial was published in The Lancet last year and presented in the late break clinical trials in the OTA meeting. And it was a big effort for many international investigators. And based on the results, we decided to perform the HIPATEC 2 trial with the hypothesis that patients with a hip fracture and the baseline elevated troponin will benefit from accelerated surgery by reducing the time exposure to the physiological stress associated with the hip fracture. So our principal research question is that in patients with hip fracture who also has a baseline troponin elevation, accelerated surgery is superior to standard of care for the primary outcome of 90 days mortality after randomization. We plan to recruit 1,100 patients internationally, same inclusion criteria as of HIPATEC 1, but here all patients need to have troponin elevation to be recruited in the trial. We're going to use same exclusion criteria, but also in terms of safety, we're going to exclude patients with ST elevation, myocardial infarction, and cardiogenic shock. The intervention will be again accelerated surgery with the goal to fix the hip as soon as possible, ideally within 6 hours after hip fracture diagnosis. And we are going to compare with standard of care. And based on our survey with many international sites, in those patients, the standard of care is usually medical optimization, cardiac stabilization, monitor troponins, and as soon as troponins are trending down, then do the hip surgery. The primary outcome will be all-cause mortality at 90 days. We're also going to look into secondary outcomes, including functional outcomes, times for mobilization, a composite of several cardiovascular complications, delirium, pain, and quality of life. In conclusion, HIPATEC 1 taught us that accelerated surgery is not a panacea for all patients. However, it did result in reduction of delirium, urinary tract infection and pain, and also accelerated time for mobilization and early surgery. And the index case that motivated the HIPATEC 1 trial was actually a patient with troponin elevation with a hip fracture. Surgery was delayed. The patient ended up having PCI, dual antiplatelet therapy, bleeding, and she ended up dying with the usual manage. So we hope that hip attack can answer this important question in terms of timing for surgery in this high-risk population. And we would like to invite you all to undertake this trial with us. Thank you.
Great. Thank you so much, Flavia. And I think that gives everybody some important things to think about, as we initially started talking about surgical interventions, and now hearing about something else that might, play an even bigger role in how these patients do. And traditionally in a patient subgroup that we would have waited on, and now it might be even more important to get them to the OR even quicker than we thought. So I think some important things to think about, and I think a great sort of segue into our next talk by Dr. Theresa Pazionis, who will review a situation where, say, we might not really be in as much of a rush, and that's to discuss the pathologic hip fracture, and a hip fracture that is a little bit of a different entity than what we've already talked about in an elderly population. So with that, I'll turn it over to Theresa Pazionis.
Hi, everyone. Thanks so much for being here. And it's great to be back at McMaster, even virtually. So today we'll be talking about pathologic hip fractures. So I'll just share screen, I guess. Is that how that? Okay, hang on.
You should be able to hopefully have access.
Should be, yes, I see it. Okay.
It seems like they put that button in a different place every time.
They really do. It's just sort of, okay. So it says launch meeting, show all windows. All right, here we go. Yeah, there we go. All right, can everyone see that?
It looks like it's trying to. There you go.
All right, pathologic hip fracture. We see that, we all see the screen? Perfect. Yep. Okay, so no financial disclosures. So the goals of presentation. So essentially, pathologic hip fracture is a very large topic, and it really does encompass an entire year of orthopedic oncologic training, as well as an entire residency. So if anyone has any additional questions, please do feel free to email me. My email is attached and below, and most people also have my personal email and number who are on this talk. So the goals are to discuss the current evidence-based treatment for metastatic disease, including metastatic acetabular disease, and to ask and answer questions that people may have regarding same. So we're going to start with the case. So the first thing is, it's a 61-year-old male who has a history of pancreatic cancer and anaplastic thyroid cancer and no known history of metastatic disease. The patient presents with increased left buttock and hip pain and a new lesion in the left periacetabular area. So what are the issues to consider? Oftentimes this happens on a staging CT, or will get called from this by the medical department after they've already evaluated the patient. So here we see that there's some lytic destruction of the acetabulum, and really this may be the cut, but it seems the femoral head is essentially gone. So the question is this a new primary? Is it metastatic disease or something else? Is this the only area of disease, and what tests should one order online? And one important thing to bring up is that a solitary new bone lesion is a primary bone tumor until proven otherwise. The worst complications that I've seen come into my practice as an orthopedic oncologist have unfortunately been when people have assumed it's metastatic and then treated it, and unfortunately then it's widely metastatic chondrosarcoma after that. So PET scan or whole dose low body CT, depending on what's available at your institution, is proof otherwise. So here we see that the patient has multiple lung, liver mets. They've also got some other bony mets that are evident. Uptake in the kidneys is normal to a certain extent, so that shouldn't be taken as metastatic disease. So this is obviously a multicentric disease, but from what primary? And the key thing here is that a thorough and multidisciplinary approach is required. So our goals today are to overview epidemiology, pathophysiology, the workup that we'll need, and some guidance on surgical therapy and new directions. So the key thing is metastatic disease does negatively impact patient quality of life. In our review of patients from my fellowship at Sloan Kettering, we had oftentimes patients developing disease in the pelvis and the acetabulum, and currently in my practice, I see about 10 new patients a week who have disease in some shape or form in the acetabulum or lower extremity. Lesions often progress to cause mechanical incompetence of the hip joint, resulting in functional pain and pathologic fracture. Non-operative management of pelvic and acetabular metastases can be restricted weight bearing depending on the patient's prognosis, radiation, anti-neoplastic agents, narcotics, and bisphosphonates. However, surgical interventions really are the key in terms of making sure that your patient remains mobile for the longest time possible. The decision whether or not to pursue surgical intervention is oftentimes dependent on both can the patient tolerate surgically from a medical perspective and their ECOG status. ECOG status is something that we'll discuss later. It's Eastern Cooperative Oncology Group, and it becomes important not only because of, hey, is your patient going to tolerate surgery or not, but ECOG is something that we use to determine whether or not patients are eligible for chemotherapy trials. So for a lot of trials, the ECOG status will have to be 3 or below, meaning that they have a fairly good functional status. And if the only thing that's really keeping your patient in bed is their pathologic hip lesion, well, you could actually cause them to be eligible for more trials than they would have been otherwise. So this is a multidisciplinary approach again, and we also, obviously the patient is the center of that. So we really look at what the patient wants, what their goals are, and what their wishes are. Metastatic bone lesions are often found in older patients, although certainly we do see younger patients who do have primary tumors. Bone is the third most common site for metastatic disease behind lung and liver. And of bone lesions, proximal femur and acetabulum is the most common site of fracture secondary to metastatic bone lesions. Spine will be second. Mechanism of bone destruction for any residents who are watching this will come up on your exam, so please memorize it. And for the rest of us, it's just important for practice and patient care, which is really the goal. So it occurs through the rank L, and osteoprotegerin pathway, and PTHRP positive breast cancer cells oftentimes activate osteoblastic rank L production, for example. Osteoblastic bone metastases also are due to tumor secreted endothelin 1. This picture oftentimes comes up, but essentially what happens is you have the tumor cells, which will then increase the rank ligand. This will then increase bone destruction. You'll get bone metastasis, and then you'll have sort of a vicious cycle where the bone metastasis will then again stimulate overproduction of rank ligand, and the cycle continues. Cancers that commonly go to bone. This is commonly tested question, but just in practice, what we see is the most common is metastatic bone disease, myeloma, lymphoma, Paget sarcoma, and post-radiation sarcoma. The last two are super rare. The skeleton is the most common site for metastasis for several visceral carcinomas, and the mnemonic that we look at is lead kettle, or breast, lung, thyroid, prostate, and kidney. What I also like to think of anything with 2 lobes. So if you look at all those, each of those, there's technically 2 lobes to those organs. Rugraph paper is something that we discuss as a sort of a dogmatic paper, and essentially what it does is it stresses the importance of history and physical examination. So in their paper, approximately 90% of all patients with skeletal metastasis of unknown origin can be diagnosed if you do a history and physical examination that's thorough. You ask relevant questions, you speak to the patient, and also do CT, chest, abdomen, pelvis, and bone scan. And that will diagnose 90% of unknown primary. So please do a history and physical examination. Social history should always include smoking or other risk factors. What did you do? Did you work near power lines? I recently had a patient who was actually from the area near Chernobyl, so that's something that does happen. Previous screening tests, what have you had? Or have you noticed anything about your body that's worth mentioning, or any lumps or bumps? Local and systemic staging, plain radiographs and chest x-ray. Please also plain radiographs of the entire limb. You want to see if there's any either skip metastasis or anything distal. And bone scan or PET is available and appropriate, as well as the following blood work, including workup for myeloma and screening tests for prostate cancer and so on. One thing I do always like to note in these lectures is something that will hurt your patient today is malignant hypercalcemia. So in my clinic, I actually have a rule that if you see me for bone lesions, you must get a calcium drawn, and we must call you with it. Either myself or my PA or my resident will follow up on that and call with that result, because oftentimes, and it's rare, but you will have a patient who comes in with a horribly elevated calcium. And sorry, my cat is right behind my screen. It's shaking. Mouse, please get down. Thank you. And that's something that can really save your patient's life if you diagnose that. So it's a medical emergency. Symptoms include confusion, muscle weakness, polyuria or polydipsia, nausea, vomiting, dehydration, but those are all in varying degrees, and someone could just be on the cusp of that. The treatment really is hydration, loop diuretics, and bisphosphonates. So any questions thus far? I think we'll pause later for those if not anything burning. So the workup for the older patient with a single bone lesion and unknown primary will include your imaging, labs as we've spoken about, and a biopsy. The biopsy should really be in the most accessible lesion if you have polymetastatic disease. That's not always a bone. Sometimes that can be lymph node metastasis, or oftentimes if it's a solitary lesion, it may be your bone metastasis. But the key thing is getting a tissue diagnosis before you administer effective treatment. Even in metastatic disease, this is important, and we'll look at some examples of that in a little while, but some tumors do require other procedures prior to surgery. So for example, embolization, which we'll talk about. The MRI is something that I do want to touch upon here. I think the AP and lateral of the involved area is really key. Looking at whether your lesion is lytic or blastic will give you a hint to the lesion. Really, pathology is going to be the answer for you. But the MRI with and without contrast will show you either is there any disease in the acetabulum, which may have you considering a total hip as an option, or is there any disease distal to the hip that you might want to consider a long stem component or a longer nail. So we look at kidney and thyroid. These will oftentimes be lytic lesions, as will most cancers, and will be decreased uptake on bone scan. The reason is because they're so terribly aggressive that the bone doesn't have time to respond. And if you think about the mechanism of how bone scan works, it uptakes the technetium into rapidly turning over bone, but if the bone doesn't have a chance to turn over, that's how cold bone scan works. So that's an example of cold uptake on bone scan, oftentimes renal cell carcinoma or thyroid carcinoma, sometimes myeloma. At my center, we do PET scans. If you don't have a PET scanner available at your center, a whole dose, low dose CT of the whole body will do as well. If you have a PET scanner, please do use it, is the key point there. But bone scan, CT, chest, abdomen, pelvis, really whatever you have at your center that does provide systemic staging. The treatment goals. So again, a lot of this is based on what your patient's wishes are and what they can tolerate. And your goal as a physician is to provide them with appropriate suggestions and what you can realistically do for them to control their symptoms and help them live their lives productively. So non-operative, everybody who I see, unless they have some horrible contraindication to this, such as, osteonecrosis of the jaw or previous, reaction to bisphosphonates, gets bisphosphonate therapy, or ex vivo, which is denosumab. They oftentimes will get radiation as well, but by and large, unless they have really prohibitive lifespan to having surgery, they will be getting stabilization. So stabilization of the complete fracture and postoperative radiation is most common. Radiation also provides pain control and it prevents the tumor from spreading and causing construct failure. Prophylactic stabilization of an impending fracture as well as postoperative radiation if the impending fracture meets the criteria, which we're going to talk about in a second. It's called Morell's criteria. And preoperative embolization is indicated for vascular lesions such as renal cell carcinoma. So we'll review my publication, Embolization of Hypervascular Bone Metastasis Reduces Intraoperative Blood Loss. It's a case control study essentially looking at a variety of patients that we had at Sloan Kettering. 41 patients that were renal cell with tumor matched, age matched, and sex matched patients. And essentially, patients got less transfusions. Anecdotally, they had lower length of stay, although that wasn't statistically significant, and they were most significant for open femoral procedures. So the cases that we are discussing in present. And it's considered standard of care to embolize these lesions. Embolization protocol, this is an example of it. So essentially, you'll have this tumor here. This is from renal cell. This blush that you'll see in stage B is the hypervascularity of the lesion. So I have seen, this has happened, where you embolize a lesion and it's not entirely adequate embolization. Blood can literally spray out of your entry point for your proximal entry point for your nail. So don't underrate how badly these can bleed. This can lead to compartment syndrome. There can be a lot of problems. So here, the embolization's been completed. You still have the femoral vasculature intact. That is important, but you can see the blush that's related to the tumor is gone, and then this has been cemented and nailed in the appropriate manner. So my protocol for this, and this is the standard of care protocol for renal cell thyroid, sometimes myeloma and sometimes hepatocellular. You want to consult with interventional radiology and plan your surgery and their embolization. So it's 24 to 48 hours preoperatively. For some reconstructions, you might consider neoadjuvant radiation, in fact, if it is really, really vascular and they didn't feel that they could coil it effectively. But that's only if you have time and if it's not broken. book a case with plan for transfusion unless the patient says no, essentially. And a lot of times patients will ask about cell saver. My thought on cell saver, and they've actually done sort of preliminary studies on this that really hasn't been published, and it depends on what your blood lab will agree with. Technically, a contraindication of cell saver is widely metastatic disease or tumor or infection. But if you have a patient who already has widely metastatic disease, if you actually look at how the red blood cells are processed through the cell saver, you're not going to get tumor cells that are viable. And this has actually been tested in what they take out. So if a patient is a Jehovah's Witness, for example, and we do have a large Jehovah's Witness population about Temple, they already have widely metastatic disease and they will die now if they don't get blood and have their fracture fixated. We do allow use of cell saver for cancer cases. And I think that's becoming more and more common as we realize that the risk is in fact theoretical. So now we'll talk about Morell's criteria, risk of pathologic fracture. I have my patients, we calculate this, we put this in the note, and this is very important for resident teaching, but I think it's also poorly understood. So essentially you look at the site of the tumor, the pain that the patient's in, is the lesion blastic, mixed, or lytic, and the size. So it's greater than 2/3, 1/3 to 2/3, or less than 1/3. Technically in the original document, that's erosion into the cortex, but it's widely become used as, percentage of the bone that's involved, okay? Most of the time, if you're thinking of fixating it, it'll be fairly obvious, and a 3 will be a 3, but technically it is cortical involvement, not technically medullary involvement. So it also doesn't mean that you're absolutely going to break it if your Morell score is greater than 8. It's a 33% risk, which is what we've decided is prohibitive to letting the patient be, unless there's other factors, and you should consider stabilization. So what it does tell you is the risk of fracture. It does not tell you if you should operate on a patient, and it also does not tell you how to fix the lesion. It only tells you the risk of fracture, and then you can do with that information as you need to. The more, yes.
Sorry, I don't want to cut you off too much, but I just want to make sure we have time for Dr. Slobogean.
Oh, sure. I'll hurry up. I'll hurry up a little bit. So essentially, this is PathFX, which is something I do want to bring up. When you look at this, you can actually calculate your estimated survival. It's pathfx.com, and you can see the probability of survival over 24 months. Essentially, it's based on numbers that you will have. There are also examples that you can kind of look at and run your case through, basically femoral head, neck, and intratrochanteric femur, for example. These are 2 cases from PathFX where they talked about a cemented long stem hemiarthroplasty or a cephaloid medullary nail. And those are both ways that we fixate things. The key thing that I want to bring up is for the cephalomedullary nail, I do a biopsy and curettage of the lesion first, because I do think that there's a theoretical risk of showering tumor into your systemic circulation, 1. And 2, it also helps decrease risk of progression. So if you nail something and you spread it down the canal, that is more harmful than not. So please do deal with the lesion locally first by curettage, either adjuvant therapy with ablation or with just high-speed burr if it's amenable to that, and then pass your nail. So we'll talk a little bit about this. I'll be a little bit brief. So the key thing is, if prophylactic nailing for an unknown solitary primary, no fracture. So systemic staging, consult orthopedic oncology. If you don't deal with these lesions often, it's very reasonable to speak to an oncologist. Call me, call anyone. We're always happy to talk to you. Intraoperative biopsy and frozen section. If it's metastatic, or if it looks metastatic, local treatment of lesion, IM nail with cement and postoperative radiotherapy of the entire bone. If sarcoma is suspected, you place some cement, and that's both good for hemostasis and it's good to kind of stabilize things a little bit. Close, non-weight bearing, wait for definitive pathology, and then consider wide resection if appropriate. Another reason why you might want to consider wide resection is for longevity of construct. So this was a very large lesion that was initially treated with a nail, and then the patient, very luckily, outlived the nail. So oftentimes, if survival is expected to be greater than 6 months, which you can use that tool as your estimate, it's considered worthy of a long stem hemiarthroplasty or equivalent. We oftentimes as well talk about resection of solitary metastasis. This is a recent item in the literature. The classic literature was if recurrence with a single metastasis was greater than 10 years from the primary, resect with curative intent. You also look at the morbidity of the patient versus the morbidity of the procedure. And is the bone viable and how aggressive is the tumor? So if the tumor is expected to grow and eat through your construct, you may just wish to take the entire thing out. There's been a study by Val Lewis at MD Anderson as well. Should you always use a long stem? The dogma is to protect the entire bone within reason. But there's also a risk of tumor cement or fat embolus. If there is tumor distal, you should always use a long stem, but otherwise it doesn't seem to be associated with less, positive outcomes to use a shorter stem. If you are using a long stem, please do a vent hole. I can't stress this enough. It is part of the standard procedure from an orthopedic oncology perspective. What I mean by that is you provide a hole sort of mid-shaft femur for excess cement to come out. That's not as important in standard arthroplasty. But for tumor arthroplasty, you have very large vessels oftentimes that are associated with the tumor, and your risk of cement embolus goes through the roof. I think the worst case that I saw in fellowship was a lady who ended up with a cement embolus and then a stroke from an undiagnosed ASD. So things like this do happen. So please do a vent hole. This is another case essentially that we can kind of move through a little bit, but essentially she was very healthy, breast cancer, and then she fell.
Teresa, I think maybe we'll just move on if they're
yes,
that.
absolutely.
And we'll talk some cases potentially if people are willing to.
Yeah.
Later.
If people want, I'm very happy to. Sorry, it's a huge topic, so thank you so much.
And we appreciate you trying to cover so much in such a short period of time. I just, thank you so much for giving us some great information on definitely a different entity in terms of hip fracture. And I think important to discuss as separate sort of management principles, which I think you did a great job of. So thank you so much for
Thank you. No, and anyone who has any other questions, call me. This is Oncologists. We talk a lot, so please feel free.
I love your cage. Looks good.
It
Thank
looks
you.
good. And I think, I just want to be fair to everybody kind of.
Yeah, everyone. No, this is a great seminar, so please.
And, I just want to let everybody know we said we'd end at 8, but if, we're just going to, I'd say, let Director Slobogean he was planning to give about 10 to 12 minutes of talks on open free management of young adult femoral neck fractures. He was going to talk about open versus closed reduction as well as implant choice. Now, if everybody's willing to stick around a little bit longer, I'd love for him to go through both of those talks, but we'll kind of see how time is running and if there's a.
Let's do it.
Let's do it. Yeah.
Jump on it, guys. All right, sorry to go. I'm going to turn the floor over now to Dr. Slobogean, who will again share some information on a different entity of hip fracture than we typically would think of, and some important treatment principles that we need to consider when talking about high energy young adult femoral neck fracture. So I'll turn it over to Dr. Slobogean. Yeah, and I think that's up. We can see your slides. I think we just got to get you unmuted.
There we go. Sorry about that.
No worries. Awesome. Thanks for joining.
No problem. And let's see if we can get this. There we go. Can you see everything full screen?
That looks good.
I see this presenter notes. I think you just need to hit the swap displays and it'll be good.
How about that?
Perfect.
Okay, so I have 37 slides. I'm going to go through 3 of them. So young femoral neck fractures. I have no financial disclosures. I previously held a CIHR grant on this topic, but really this is, a continuation of the tribute to McMaster and COTS and all the wonderful work on this topic that's been done through Canada and through the network that Mo and Sheila and everybody has built. So the clinical problem hopefully is pretty obvious for a lot of you. Femoral neck fractures in young patients, they're not geriatric injuries. We have very different goals. The goal of joint preservation, unlike what Dr. Leighton was talking about. We also know that the fracture pattern is often more vertical and comminuted, and really internal fixation is the mainstay of our treatments. Unfortunately, when we go down that route, more than 30% of patients are going to experience some sort of fracture-related complication, whether it be non-union and AVN that we most typically talk about, but also there's a lot of other reoperations that occur and even severe shortening of the fracture, which is associated with really poor outcomes clinically. So fortunately, I put this hyperlink in here, so I actually can just skip through a bunch of my slides, and we're just going to go through, these are the three main treatment controversies that I think are sort of persistent right now. Time to fixation, which frankly has gone away. This is no longer a middle of the night case, but it used to be. Open versus closed reduction of the fracture, which I think has some merit, but also is over talked about. And then surgical implant choice. So I'm going to skip right to surgical implant choice. We'll talk about this for a little bit, and then we can decide if we want to go back and forth. So Herman, can I put you on the spot real quick here and ask you, do you have a preference? We know cancellous screws and sliding hip screws tend to be the two most common used devices. And I've put up some of the benefits and disadvantages of either, but for young femoral neck fracture patient, do you have a preference?
I would say my preference is kind of leaning towards sliding hip screws with an anti-rotation screw. It'd be great to hear what the rest of the panel would choose. Ross,
can I put you on the spot?
I've gone the same way. I've used to be sort of multiple screws, but I think with the help with the face trial and everything, I moved to more to a sliding hip screw and again a derotation pin of some sort. Yeah, same thing.
Cool. All right. So I will obviously share with you guys what I'm doing now, and it's interesting because I think that the faith trial has affected me a little bit, but maybe in the opposite direction. So let's see if I can get my slides to advance. Here we go. So, I think really the faith trial and then the faith 2 pilot trial really compared these two implants, and I think they can guide us a little bit in this decision. Now we're only talking about young femoral neck fracture patients, not elderly geriatric patients. So for those of you that are really familiar with the FAITH trial, 1,100 patients, it was a geriatric population. It was mainly Garden 1s and 2s, so minimally displaced fractures. And for those of you that recall the results, there was a significant benefit to sliding hip screw in displaced fractures. So there was no benefit overall, but in displaced fractures, sliding hip screws were favored. And when you look at why they were favored and you break down some of the differences between the two, these are the 4 that I think are actually most important. And so you can see these are all statistically significant. There's a number needed to harm of each one. And what you actually see is that implant removal and implant exchange, that was sort of worse in cancellous screw. So it favored the sliding hip screw. But conversion to total hip and AVN, there was more of that in sliding hip screws. So that favors cancellous screws. So for me, this is actually really important information in a population where maybe I don't want conversion to total hip, right? A young patient who an early conversion would be a bad outcome in my opinion. So that was the FAITH trial. And now we have the FAITH 2 trial. This was a pilot study that we ran for 86 patients. And you can see it's a younger population. Now we got more displaced fractures. We got a much younger age, but the numbers are small, right? This is now a comparison of 43 patients. And you see some of the same trends, you have a few more conversions to total hip in the sliding hip screw group, implant removal for pain. So you're seeing some of these trends, but I wouldn't really put too much stock in this just because the sample size is so small. When you look at the hip outcome score between the groups over time, there's some benefit to cancellous screws at 6 and 9 months. And these are clinically significant values, but then they go away at 12 months. And this may be just related to the few patients that were having some of the complications that we were talking about. I think this is the most compelling slide, which is basically that this is now the whole cohort. At a year, there's still a large proportion of patients that aren't doing well and are having mean difference changes much lower than their pre-fracture function and much higher than minimally important differences. So to summarize, we don't actually have a ton of data on this. We don't have a ton of data to guide us. But here's what I think we do know. We know that there's no evidence that implant seems to affect union or non-union in this case, both in FAITH and FAITH 2, that was not the signal. It was the other problems that we were having. We know that sliding hip screws resist varus collapse, but then that also leads to cutout if you run into problems, right? And then that gives you a conversion to total hip. Cancellous screws, they fail in varus, which leads to lateral screw prominence. And in FAITH, we saw that was a big problem. That led to a lot of extra reoperations. But in my hands, or at least in my opinion, I should say, that's less of a big problem than a total hip conversion in a young patient. So in some senses, I really wonder, is the choice actually about choosing the acceptable complication for the patient that you're treating? And so here's where my practice has evolved. So for older adults, I prefer the sliding hip screw with derotation screw like Herman and Ross, because I think the bone quality may be worse. I think a conversion to a total hip is probably okay for this patient population. But when I have much younger adult patients, I'm going for cancella screws. I think it gives me better rotational control. They have harder bone. It's easier to convert to a subtroch osteotomy, because for this patient, I'm going joint preservation sort of till the end. And then so that's going to avoid cutout and total hip. And then the last thing I just want to mention is, are there devices of the future? I think the ideal device that we'd like is something that gives that rotational control that I just mentioned, but also gives the fixed angle device, would control some collapse, allow some collapse for healing, but not too much collapse. And this Targan device, the one in the top right, is from Europe. It's not licensed in North America. It has a really good track record. Zimmer and Smith and Nephew both had really nice devices, and they've both been recalled already in the last couple of years. So the Synthes femoral neck system, the one on the bottom right, is the only remaining sort of new generation device like this, and we'll see how long it lasts. I will say, as part of the OTA program committee, I did review a nice abstract that has really compelling results in a pretty big series that will be presented at the OTA. So we'll see what happens, but I'm certainly interested in this system. So Herman, what do you think? Should we stop here and this maybe discuss open versus closed reduction, or I can?
Yeah, I think that'll be, why don't we just move to some discussion, and that
Yeah.
way we can get some questions from everybody. Thank you so much, Gerard. I think that was a wonderful kind of.
Gerard, when you do the young patients, what about the base and neck? Like, that's the one to me that occurs in younger patients more commonly, as a real base and neck. That's the one I tend to use the sliding hip screw and pin on, because it's sort of really almost like an inner trope, got a big surface area. You can compress it really well. You want kind of a big device. So that's the one that I see more frequently in the young patient versus the, direct subcapital, which is different. I tend to use screws for that one too, but I more commonly see the base and neck fracture in a young patient with a severe shear and then an associated femoral shaft fracture.
Yeah.
What do you use for that?
Well, okay. So, you put two parts in there, right? I was about
I did. I jammed a couple questions in.
Yeah. So, and then you threw in the with associated femoral neck, or with femoral shaft. So femoral shafts, I tend to do either one. Like, so, they come in two variants. One is that they're not actually that displaced because the shaft took most of the brunt. And then I'm not really too worried about what I do. And then if they're more displaced, then I go down the algorithm that I just talked about. But you're alluding to a real important key, which is the thing I said in the first slide, which is they tend to be more vertical and more comminuted. So when they're really, really vertical and they come out the subcapital region on the top, but come out the bottom of the inferior neck at the calcar, that's a real challenge. And that's a real setup for failure of the cancella screws, because there's just no medial buttress or a neck for it to buttress against. And so that's where I really want to use these newer devices. I'll probably use a sliding hip screw in that situation. The other really successful implant seems to be the combination, right? A medial buttress plate with the three cancella screws.
Thanks, that's good.
Herm, you're muted now, buddy.
Sorry, they hit the button on me. Yeah, so I just wanted to, I had the slides up, but maybe they won't come up now. I just want to put the slides up here for the cases we kind of brought up at the beginning. And then that way, if we have any pertinent questions, we can kind of discuss around those. If people want, or it'd be great to hear your quick little spiel on open versus closed reductions. What are you doing for these young adult femoral neck fractures, Gerard?
Yeah, so yeah, I have a nice spiel on that. Basically, the most important thing is you get the fracture reduced. And so if you can't get it reduced, then you need to do an open reduction. The challenge or the problem that I have with open reduction for every single fracture, that sort of philosophy, is that's typically grounded in an argument that even when it looks good on radiographs, when I open it, it's still off a little bit. And because I know that reduction matters the most, I need to open all of them. And I don't think that that's really a viable argument, because all of our research, all of our studies aren't on, did you look at it and was it directly reduced? The assessments are based on radiographic reduction. So I think if you have an acceptable radiographic reduction, you should stop there. And Sam Morshed finally published that paper in 2020, which is a really nice propensity score analysis of open versus closed reduction, and showed that the outcomes were worse, or you actually had a higher hazards for reoperation and complications with open reduction. And I think that can make sense, right? If all things equal, there's probably a biologic cost to opening a fracture and potentially, ligating the circumflex artery or whatever that you have to do as part of that exposure. And so, that's essentially my spiel. You have to get it reduced, but if it's radiographically reduced, just stop there.
Now, the one thing I was involved in Sam's study, and really glad he got it published. But one thing we couldn't dissect out was, could you do it with a Smith Pete plus an associated lateral versus a direct lateral approach, right? And of course, the ones that I tend to like doing is doing through the Smith Pete and do the lateral approach with the fixation. But when you combine the two of them, you wonder if you don't get more, arterial injuries when you just bump the neck. But it was too few patients to dissect that out. So, but I'm like you, I actually switched a bit based on that study, and I look more at the X-rays, and if I'm happy with them, and it's 99% good or 98%, I just go ahead and fix it. So I do less open reductions after we've done that study with Sam. So.
Yeah, I think the last thing that's come out in the last several years too on this, and also out of faith and other things, is the lateral actually matters, right? Like as a junior resident, I never looked at the lateral. I couldn't even figure out how to look at the lateral X-ray, right? And the lateral matters. If you got a bunch of apex anterior, that's not going to do well.
Oh yeah, it's the top, yeah.
Yeah, definitely underappreciated, but I think it's great to sort of hear some other ortho dogma kind of fall as we kind of move away from every young adult femoral neck fracture needs to be open. So
right, yeah.
Great sort of summary finding. Thanks for sharing that. Now I just want to switch gears a little bit and sort of highlight the middle case here. And if anybody else has a question, it'd be great to get them in the chat or just speak up or raise your hand. But certainly we would also respect if people have to take off, given that we've gone a little over. I just want to ask Theresa. So for switching gears, talking about pathologic or atypical hip fractures. Now we got that one in the middle, and that was bisphosphonate related fracture that a little bit of beaking on the lateral cortex and cortical thickening and an undisplaced fracture. So we're going to nail that, and we're going to do a long nail and protect the whole bone. My big question with these is, how long are we stopping bisphosphonates for after? Do we have to stop them? When are we starting them? Who do you get involved in that decision?
So that is a great question. So anytime, firstly, if this is just bisphosphonate related, which it certainly looks like with the beaking, I generally just stop the bisphosphonates, and then we get their bone endocrinologist involved. We speak to them, and then I will repeat a bone density to see how long they've been on it. Do you obviously need to fixate the other side and questions like this, but generally that is a bisphosphonate ending injury, at least in my practice and what they're doing now in the States. It may be slightly different in Canada, but just with the medical legal atmosphere, that's usually just no more bisphosphonates for that patient.
So stop altogether and get the endocrinologist involved, which I think is a good way to stay
Correct.
safe and get them on the right treatment. And, we kind of put them on hold, but then do we start making it 6 months or 12 months? And I think that's a nice approach.
Yeah. They consider it a year. I have had one person go back on bisphosphonates who was a cancer patient, but again, it was sort of a mixed picture with, was it a bisphosphonate related fracture or was it just progression of their breast cancer? So a lot of times in the oncologic population, it is a little bit of a mixed bag. My thought would be in a non-cancer population, that would be a time where if the bone density were acceptable and if they didn't have any further osteoporosis related incidents, I would opt to keep them off the bisphosphonates at that time.
Great. And then just sort of the last new topic to highlight and sort of some questions that come to mind is back to timing. And it'd be great to get some input from Flavia as well as the rest of the panel. We sort of talked about it a little bit before the session started, but we're all sort of dealing with this situation now with COVID, where we're trying to figure out what the right priority is for some of these fractures and how much should we push on them. And we're all vying against priority with the other surgical services now. Hip fractures we've sort of traditionally thought of as a within 48 hours type of problem, and we're sort of moving that target hip attack sort of focused on a 24-hour threshold for these, and then the before after 6. Now that we're in this situation of determining surgical urgency, how should we be booking these? How quickly should we push the priority on in your opinion?
Yeah, well, it's a great question. Actually, I think we need more data in terms of expediting so fast the surgery in 6 hours. But I think it's critical to decide which patients actually would benefit most from expediting surgery. So I think the idea of studying this population with high troponin, it's very important, because then we can make, a clear statement, even in guidelines, that those patients should definitely be expedited if we see mortality benefit. And then I think the only way to respond to this question is actually like recruiting patients in the trial. So I was touching base with people in the chat, just, as the more sites we get in, the faster we'll be able to answer this really important question.
Great, and it's great to see enthusiasm from the attendees and getting involved. So that's awesome. Ross, Gerard, Theresa, as you guys are just sort of facing priority situations in your center, are you guys pushing them to all get done before 48 hours, or now that we're sort of maybe fighting against other services, are we letting some of them creep over? Or what?
We try and get them in 48 hours for sure. We were the worst in Canada 5 years ago, so we had to put a priority. But I must say, when we were going through that phase of the COVID, and from March till June, they were waiting far longer than 48 hours for sure. But since July, we've been back on track, and I'd say we get the vast majority. The biggest ones we worry about are really the ones that are on the anticoagulopathy drugs, and so they tend to wait a bit, and I haven't quite solved that yet. There's always that worry of do them right away or wait till they can get a spinal. So that's the kind of, I try and push the GA and do them anyway, but that's not always accepted.
Yeah, and we're definitely having to consider different risks now, right?
Yeah.
So
Yeah.
what's the risk trade-off? And we're all sort of we have to get the anesthesiologist involved, the internal medicine team, and we're kind of get stuck waiting sometimes 3 days for some 4 days. And
I love Predexa because you can do the reversal and carry on. It's great. It's instant. I don't know if you've used it, but it's like, it's good, and it's lasting till you start it up again. So, but it does cost about $2,500.
I was gonna say, we're not that rich out here.
Yeah. I'll tell you honestly, in doing spine, I think my tolerance for everything but spine and operating through anticoagulation has just really gone up. So for a lot of the oncology cases, if it's not hypermetabolic, I'll just operate right through it if they're broken. And
I love to do that. I just can't get them.
Yeah.
Sometimes they want to just do a spinal and I can't do it, right? So
Yeah.
as far as surgery goes, I wouldn't stop for anything. I just keep going. Yeah.
Mm.
And just while we're on the topic, timing in a slightly different patient population, you sort of mentioned where the young adult femoral neck fractures, in terms of timing, they're no longer middle of the night kind of cases. Are you guys still trying to get them done within 24, 48 hours, though, or what's now your threshold?
Yeah. As soon as possible. Yeah.
Yeah.
I mean, as soon as you get the team organized, I would do it.
Yeah. I mean, I think
We've honestly
the
done the middle
caveat,
night.
yeah, the caveat to that, right, is that reduction matters. So I think everybody knows that their tolerance for an okay reduction as opposed to a good reduction definitely changes at 3 a.m. And the interest and the help that you'll get from other people may change at 3 a.m. So I think that's just another reason to wait and do it at first case in the morning.
Yeah, I would agree.
Mm-hmm.
Now, I just want to be respectful of everybody's time. So just if there's any other questions, by all means, please sort of speak up or type it into the chat. This is what we did in these cases that I sort of reviewed. That the first one was the valgus impact for non-displaced hip fracture. We opted for screws there. The second one was the pathologic. So we did a long cephalomedullary device. And the last one, young adult femoral necks, chose a sliding hip screw. We sort of heard a little bit about opinions from what's right versus what's wrong. The geriatric femoral neck, you could argue, based on Gerard's talk, potentially the sliding hip screw may be a better option, but you sort of pick your complication. Some might have jumped just to a hip replacement, or sorry, a bipolar in that situation as well. And I think it's certainly what's better in your hands. And the discussion there comes up that what's displaced versus non-displaced, and I think the lateral is really important, and just was sort of displaced, non-displaced in all planes or impacted. The second one, the cephalomedullary device, and I think we could have used potentially a gamma type of nail versus a recon, but that just kind of more has to do with the curvature, radius of curvature of the leg. And I think my critique for that for sure would have been we could have used a gamma instead, which might have matched the bone a bit better. And the last one, the sliding hip screw, potentially we hear cannulated screws, cancellous screws might be a better option for this patient. But again, I think pick your complication is the message there. And would open it up to any comments or critiques on any of those. But we also want to kind of move it along. So any burning questions or points on any of those cases, guys?
When you did your sliding hip screw on the final patient, what's your technique? You put pins or a few pins above it to avoid rotation when you put it in. It's usually pretty good bone, right?
Yeah, as
So-
many pins as possible.
So 2 or 3 pins up above and to avoid torque. Yeah.
And or possibly an anti-rotation screw instead to kind of help a bit more. Now, Gerard, are you using the femoral neck system much? We don't have it here yet, but
Not much. I've done 2 cases now, I think. The funny thing that I want to mention is obviously it's new and shiny and so probably really expensive. It's actually the same price. And the reason is 3 cancella screws plus 3 guide wires plus, like it actually adds up. You're over $1,000 in implant costs, and we've got that new femoral neck system for about the same price. So
Okay.
don't immediately assume it's way more expensive than what you're using, but look into it.
yeah, and I think it sounds like that'll be available in Canada hopefully this year. So and soon. So potentially we'll be seeing if there's a new preferred choice, but always important to consider the options and the other issues like cost. And it sounds like that might not be as much of an issue here, which is great. Now, I just do want to kind of respect everybody's time, as I mentioned, and want to bring things to a close. I want to say a huge thank you to all of our speakers for sharing their part of their evening with us in this initiative and trying to connect virtually and get people thinking on some slightly different topics to common issues that we deal with, and we'll see on call for sure. And then also want to give a heads up for the next week's session. And next week, we're going to be on Wednesday instead of Thursday. So heads up the day, different day of the week. And we have an excellent talk. We're really looking forward to it on patient recovery and expectations following trauma, which is again, a complex topic that everybody needs to navigate who takes a fracture call. And we'll get lots of interesting perspectives, both globally and locally. So definitely, hopefully you can get people logging in next week. And then the week after will be a whole session just focused on cases. So then a lot of the discussion will get on clinical aspects based on the topics we cover over the previous week will hopefully be unearthed there. And then we welcome everybody to participate. So thanks again, everybody, and a special thanks to our speakers for sharing the evening with us, and hope everybody in the audience enjoyed participating.
Thanks, Herman.
Thank you.
Thanks, Herman.
Thanks. Bye-bye.